Welcome to Make America Healthy Again. Join Dr. Charles Antinori and friends as they share solutions, tips, and insights that only doctors know for creating better health. Here's Dr. Antinori.
So this is the Make America Healthy Again podcast. I'm Dr. Charles Antinori. My guest today is Donna Spross, RN, who runs our wound care facility. And we're going to be talking about wound care primarily, hyperbaric oxygen, and other issues today. Donna, do you want to introduce yourself?
Sure. Sure, absolutely. Thanks for having me on. I appreciate you thinking of me to include me in your podcast.
Well, I'm glad you're on. It helps out.
Yeah, sure. Anytime. As you know, I am very passionate about wound care, so I really don't pass up many opportunities to discuss it. So, as you said, my name's Donna Spross, and I am a registered nurse. Nursing is actually my third career. My first go round at college, I got a degree in accounting, and I worked as a public accountant for a short time before realizing that just was not something I really enjoyed very much. And then I went back and worked on my master's in secondary ed mathematics, and I taught high school math for a number of years. And after having my 4 kids, I decided I wanted to get into healthcare, so I went to nursing school. And, a number of years later, here I am. And I'm kind of putting all my little experiences to use in the role that I am in currently in the wound care centers. So,
until you told me that a couple of days ago, I really never would have guessed all that. And I can't believe you did all that. Just, nobody's going to see this, but you definitely don't look old enough to have gone through all of that. Did you teach calculus? What did you teach in high school math?
No, I taught the algebras, Algebra 1 and Algebra 2.
Algebra 1 and Algebra 2, yeah.
So
calculus was the hardest thing I think I ever had to study. That was the only thing that made me fear,
Yeah, it was difficult. I was pretty happy to get picked for the algebras,
algebra is logical. Algebra is very, very nice. It's so you get answers. You get it's like surgery. Yeah. You really get results. You get
Although teaching it to like 14 and 15-year-olds is not
easy, huh?
Yeah, their brains work a little,
Yeah.
And I was in the inner city, and it was I had kids on many different levels, large class sizes, 33, 34 kids, and it was tough. So
yeah, my school was a Jesuit school. Everybody was it was pretty easy. Algebra and stuff was pretty easy for everybody. In that school, but it's a completely different. What inner city in Philly?
Yeah, over in Philly. So that was the late 90s, early 2000s, and it was it seems like a different life at this point. But
I imagine it. When I talked to I think I told you I just did career day at my granddaughter's school Tuesday, and it's the third time I've done it. And I outlined the course to be a doctor and the course to be a nurse. I also threw in like a lawyer and MBA too, just to kind of show them the years. And I really, lately I've been showing. I really think nursing is just it got a lot of things going for it. The way things are going with medicine, but some of the people were saying they're kind of discouraged with nursing now. Jess was saying that she's thinking of going into it, but she was saying she's discouraged with it a little bit. But
nursing's tough. It's physically demanding, emotionally demanding. Some days are very rewarding and are easy, just because you're helping people, and other days it feels thankless and you feel like everybody's whipping boy.
Yeah. Doctors the same. That's true. Yeah. Absolutely. I think the biggest thing is you can get through nursing without being in the huge pile of debt that they're right now. Like I'm saying, all my surgical residents, every single one of them was $250,000, $300,000 in debt, and they didn't own anything except maybe their car. That was about it.
Yeah.
And then
that's what I didn't. I didn't exactly take the easy straight route right into nursing. So I have doctor level debt without the doctor's salary.
You're right, right. Yeah. Really? Oh God. Yeah. Jeez.
So I did, I did end up doing my MBA as well. So I said, if I did undergrad and a bachelor's in accounting, I might as well do the master's as well.
Wow, that's
Um,
great.
but it is, I
Anyway,
mean, nursing's very, very rewarding. It is.
yeah. And
It
what I
is.
like is you can pick your hours to a certain extent. There at school, when your kids are growing up, you can have school nurse. I think doctors can do the same thing too, to a certain extent. It's not as easy. Not for surgery, certainly not as easy. Uh,
Yeah, I mean, when mine were very young, I did night shift. And, in the grade school, I did night shift. And
uh,
then at one point, I did home care, and that worked well with our family schedule.
right.
And now I'm like doing country club nursing on Monday through Friday, 8 to
Right.
5 gig.
Right.
No holidays, no weekends. Outpatient wound care has been pretty nice.
Well, I'd say the same thing for me. This has been like since I retired from surgery, just doing wound care. It's been like a walk in the park, really. But for
Yeah, well,
exactly the same reasons that I get like one phone call a week from that something I have to do for a patient or something and it's never in the middle of the night. It's always during
yeah,
the day that I got to change a prescription or something like that. You know what I mean?
yeah. The
It's
home
really,
care agency wants to change an order. Or,
yeah,
yeah,
right.
it's
It,
definitely not the same type of schedule as as a surgeon who's actively,
yeah.
operating. We're lucky that you were so kind to stay on with us for so long.
Yeah. Well, like I said, I enjoy it. I really, and what we were talking about, I've always enjoyed it. I was starting to tell you that, I did it. Well, to me, like wound care is in many ways like the heart of surgery. You're making wounds. So, you got to try to make sure that they heal. Uh,
Yeah.
and
Uh,
I was saying when I started out, especially we were doing mostly cardiac and vascular surgery when the first 15, 20 years I was in practice. And I had partners that basically did exclusively cardiac surgery. And if they got a consult rolled in on their day on call or something like that for a decubitus ulcer, which we used to call pressure ulcers, decubitus ulcers. They would have a residents go see it, and they wouldn't see it. I would usually end up just going to see it, just so that some kind of an attending would have been looking at it.
oh
Uh,
yeah.
they,
Our surgery offices are very thankful to hand over their, non-healing surgical wounds
right,
or any chronic wounds that they come across,
right,
if they're on call in the hospital to come in, because there aren't too many surgeons that really love wound care.
yeah, it's funny.
Surprisingly.
Surprisingly, well, I hate to, I don't know if I hate to say it, but part of it might be like when you do an operation for 90 days, that patient is yours, and the office visits are all part of the global period for any operation, bigger than starting with a hernia, basically a hernia or any operation that's bigger than that usually has a 90-day global period. So if you're seeing that patient every week, you're basically seeing them every week or every 2 weeks. You're seeing them for nothing every week or every 2 weeks,
Well,
basically.
and see, that's why they should love chronic wounds, because surgical debridement codes, when they take those patients to the OR, it's a 0-day global period.
Right. Is that right? Is that a 0-day global period? I didn't know it. Yeah.
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 So
Wow.
debridement of subcutaneous tissue, muscle
Yeah.
fascia, even
Yeah.
down to bone. Yes, 0-day global. I mean, technically you could debride them every other day if you needed to. We
Which
don't
we
want to
do.
do that,
I've done that. I've done that with some of the really bad wounds. You just have to take them to the OR because it's kind of a big production. They're massive. Some of these wounds. The people that, like we were talking before about so many. The reason we have so many chronic wounds is because of largely obesity in the United States, which spreads to diabetes and hypertension, and then
Yep.
throw in cigarette smoking, which creates peripheral vascular disease and just poor healing all around. It's not, when I was on call, it was not unusual to get some giant abscess or necrotic wound,
Right.
every time you're on call. And, many times it took 2 or 3 trips to the OR to get that cleaned up. It was just too painful to do it bedside.
Yeah.
Too big of an operation to do it bed. It's a simple operation, but just too painful to do it at bedside. And you need equipment. You need stuff to irrigate and the Pulsivac, for example, and to really clean. And then nowadays we put the wound vac on, and a lot of the wound vacs we see are like fairly simple, like a small wound, and you just it's not. It takes probably 5 or 10 minutes to put the wound vac on. But some of these wounds are so extensive that it just takes half an hour to cut the foam and put the tape on and get everything covered.
Yep.
I joke around about it. When I was in first grade, we had a Think and Do book. It was just a little book, and they'd give you a little assignment to fill out or something like that. And then the nun that we had, I guess to give you the idea of doing homework, the nun would make us cut out stuff out of the Think and Do book and like paste it into a notebook, and then then she we used to call it cut out and paste, and then she would just check it. She would just have everybody hold up the book. She wouldn't even like walk down the row or anything like that and look at what you did, So I'd be doing it at night with my mother, and I'd be telling my mother, like, this is the dumbest thing in the world. Why the hell am I just cutting this thing out of the Think and Do book and pasting it in this other notebook, because I'm telling her, she doesn't even look at it. Then, 70 years later, there I am in the OR, cutting out and taping,
That's we definitely, that's what I tell my staff nurses, you have to be creative and be really able to like think outside the box and do some arts and crafts.
It's very crafty. It is very crafty, and try just like I say, it's interesting too, trying to find the different. Sometimes you do one kind of wound care and the thing gets worse, so you try something different. A lot of it is just totally empirical, but by and large, I mean, what are our statistics? We heal 80 or 90% of the wounds that we see, something like that, most of the time.
For patients who continue with care and don't just disappear on us, because unfortunately, we do have probably 8 or 9% of our population that they'll start treatment and then just stop coming. But for the patients that come, we have over a 95% heal rate for patients.
Is that right? Wow.
Continue. Wow. Yes. Continue through the therapy. So, I mean, there are so many, like I said to you earlier, I've been exclusively in wound care for about a decade now. And the advances that we have made, even in that time, are like so tremendous. Some of these wounds that, we would be spinning wheels on and just not able to make any headway for the longest time. Now we're, maybe it's adding moisture to the wound bed because, I remember when I first started, everything was wet to dry, wet to dry, wet to dry.
Yeah, I was one of those guys.
Yeah, wet to dry.
Yeah.
And we've learned in the more recent years, like, no, a dry cell's a dead cell. We want to have a balanced moisture wound base to promote healing.
Right.
And that traumatic effect we were having removing those dry dressings was causing more harm than it was doing any good. So
I would say I was off the wet to dry by the time you came along, but in much of my wound care career, wet to dry was a way of dealing with dirty wounds, to debride them, to clean them up. Before the vac, the vac does a lot. The vac does it much better. The vac debrides wounds. The wound gets kind of sucked up into that foam. The detritus, the devitalized tissue. Gets sucked up into the foam kind of, and when you take the sponge out, you remove a lot of it. Like after you do the vac a couple times, usually, even if you have to get a wound relatively clean before you put the vac on. It's not gonna take care of a big eschar or something, but a little bit of slough, the vac will take care of with time. Every time you change it, it gets a little bit better. I mean, that is
Yeah.
like that. And that started around, I would say, around 2000. I think the vac was basically invented in the 1990s, but I remember I don't think we used it very much until around 2000, and now it's really a mainstay. And like I said, we were talking about before we came on. It heals wounds that I had, that people used to die from before because there was just no
Yep.
way to heal. There was no way to heal some of these things.
Yeah, I mean, especially these deep tunneling,
Right.
pressure injuries, and they're so hard to heal. And the other thing, it's just we're doing better with understanding like how nutrition plays a factor in healing.
Right.
We're better at getting appropriate support surfaces for the patients in their
Absolutely.
homes.
That was
And
the
just,
next thing I was going to mention, the beds.
yeah,
Yeah, because the beds, you get the good right bed, you can avoid almost, you can't completely avoid pressure injuries no matter what you're going to do. But, and that's why I always feel bad about these people that blame nursing homes. I mean, they have a very, very difficult job, with some of these patients, that are pretty much totally immobilized. It's
yeah,
very hard to keep them from getting pressure injuries. But if you got a really good sequential air mattress bed or low air loss bed, like they call it, it's amazing how much that can prevent injuries. And then the
yep,
Clinitron bed is phenomenal. It's just that it's so hard to get one, but that is just
yeah.
another thing that is just so great, not only for preventing pressure ulcers, but for healing them.
Yeah, I mean, reducing pressure, and then it's like controlling the moisture and the climate control. Because if you have a person who's stuck in a bed and they're laying on a sheet that and they're sweaty and
Right,
it's crinkled up under their body, and
right,
even if they slide just a little bit, that the skin barrier is damaged from being wet.
right.
And then it just shears that top layer of skin off, and then just that
You're off to the
the
races, right?
cycle is started,
Right,
and here we
exactly.
go.
It gets
Here
bigger
we
and
go.
bigger. Yep. And that's what used to happen. Like I said, it got to be impossible to deal with it. The wounds just got bigger and bigger. But between the beds and the vac and just better wound care products, like you brought the Vash to our place. I hadn't seen Vash,
Yes.
before that. That's been a godsend. I think that's a nice combination between, of moisture, and yet it sort of dries things out, and it's antibacterial, but it doesn't seem to kill tissue. It really is
Right.
a
Yep.
nice.
It's non-cytotoxic, so it doesn't kill your good tissue.
Right,
You know, it's not stringent that where it's going to cause harm, yet
right.
it kills like 99.9% of bacteria, like pretty much on contact.
Yeah,
It
and it's
promotes
cheap,
like,
relatively speaking. I mean, the patients always get upset when it's $25 for a bottle, but really, in terms of what we spend on healthcare, that's
yeah,
really
right.
peanuts. And very few people even spend the $25 a bottle for it.
Yeah, well, and the problem, that's one of the things, access to supplies. And
Right.
that's one of the biggest, barriers that we find with our populations, because the insurance companies don't, and let's just be frank about it. There's tons of waste in all areas of medicine, and
Absolutely. Right.
wound
Right.
care is not exempt from that. And because it's such a huge expense to the insurance companies, they had to put some rules in place. The problem is they no longer pay for any wound cleansers at all. That's not covered. It doesn't matter the extent of the wound.
Right.
And we know that wound hygiene is like one of the most important things in
Cornerstones. Right.
healing.
Absolutely.
I mean,
Yeah.
if we let it
Yeah.
get dirty and
Yeah.
colonized, critical colonization, like it's never going to heal. It's going to become infected. We have to make sure it's kept clean, and it's not covered. So
Right.
patients have to pay out of pocket. And these patients that have these wounds that do not heal, and maybe they're huge, like both bilateral legs or circumferential, or they have giant, like their whole backside,
Yeah.
it's expensive.
Yeah.
It's a very big expense for people.
Yeah. It's really, this is the thing. This is what, in the book, my book, Make America Healthy Again. That's what I kind of tried to talk about, the fact that like healthcare has gotten better and better, but that has also made it more and more expensive, because
Yep.
it's just everything costs money, but doctors and nurses and clerks, technicians, time costs money.
Yeah.
Even without I agree with you too. There's tremendous waste. I mean, probably not nearly as bad as a lot of other areas of our country, but even so, there's a lot where a lot could be. I talk about like the OR. We throw on these gigantic sterile drapes that have to cost like 50 or $100. To do a dirty case. You're gonna debride somebody's dirty sacral pressure ulcer, and you put
Right.
a giant sterile. You go into the OR, they sterilize the room. You put a giant, you prep them. You put a giant sterile drape on there. Everybody puts gowns and gloves and everything. And all these things that are sterile when you're working on the dirt. If it was just clean, to try to make things more sterile, it costs so much more than just having something clean.
Yeah. Well,
Yeah.
I have my thoughts on sterility are that we'll save that one for another day. But
Me too. It's controversial. I mean, I'm all for hand washing, but I think
oh,
it's gotten to the
absolutely.
point where it's like a religion to a certain extent. It doesn't make it. They wanted us during COVID to you know, wash your hands, put on gloves, go in the room, take the gloves off, wash your hands, and then wash your hands again before you put on gloves again to go into like the next room.
Yeah, so the requirement, and I don't know it, I believe it is a State Department of Health recommendation,
yeah,
is that every time you change your gloves, and in wound care, especially us nurses, we're changing our gloves probably 8 to 10 times per encounter.
yeah,
Um, every time we change our gloves, we're required to either use gel or wash our hands with soap and water.
yeah.
Um,
Well,
every single time.
yeah,
So it's a lot.
yes,
And I get the importance for passing bacteria, especially to other people, right? We don't want to contaminate
right,
one person with another person's body flora.
right.
But it, yeah, I don't know. I'm not
It's
a,
gotten to be. When I was an intern, back then they wanted you to do a surgical scrub. I think it was 10 minutes. It was at least 5 you were supposed to scrub for. And when I rotated through pediatric surgery, some of the pediatric surgeons would do like 6 or 8 hernias a day. They would the little kid hernias. They would do them in 20 minutes. And I'd be scrubbing for 5 or 10 minutes. By the second day on the service, my hands were like raw.
yeah.
Just from
Well, I,
and scrubbing with the brushes, you know what I mean? Like and
yes.
betadine soap and fairly caustic soaps that we used to use too.
Yeah, yeah, yeah. I hear you. I mean, I know my nurses, us wound care nurses, our hands at you. If we see 10 to 15 patients in a day,
Yeah,
time 8 to 10 pair of gloves per patient,
yeah,
that's a lot of hand washing. That's a lot of sanitizer. That's a lot of hand washing.
right,
So, especially
right.
this time of year. Um, I know it's important. I'm don't anybody think that I'm belittling the importance of
Right, right,
infection prevention and hand washing. My infectious disease brother would not be happy that.
right, right. But it is a lot. I think we're on the same wavelength. While we're talking about expensive things, we talk a little bit about hyperbaric oxygen. There's one that is expensive,
Yeah,
but yeah,
it's I mean, I believe the hype. I drink the Kool-Aid. I
yeah,
know, some people don't.
yeah,
I've had conversations with physicians that just don't buy into it. I've seen it work, so I'm a believer. I've read the studies here in the U.S. We're very limited in what we can use it for through insurances. I think what is it? CMS pays for like 11 indications.
yeah,
Where we are, we only can do outpatient hyperbaric. Some of the big university centers do dive inpatients. because they have the big multi-place chamber. It's like pretty much a room that the patients
Uh-huh.
go into and wear a hood. But in the little monoplace chambers, we mostly use that for like diabetic foot ulcers that have an infection or an abscess.
You've had to have other treatments for several months before you're eligible for that.
Yes, it's our significant diabetic foot ulcers with infection or with an abscess. Um, so if they have osteomyelitis, the infection of the bone,
Right.
um, it has to be significant for it to
Right.
be covered. And then if they have chronic refractory osteomyelitis, they also would qualify. Um, we
Radiation is
also,
the other big one, right?
yeah,
Yeah.
late effects radiation.
But
And I
you
feel
have to
like we're
wait three
seeing
months or so after radiation or something like that. I
six,
think it,
6 months, 6 months after radiation.
uh-huh.
Um, Unfortunately, I feel like the people that we have seen more in the last 5 years or so are patients that had radiation like 30 years ago for for different cancers,
Yeah.
head and neck cancers, breast cancers. And I
Yeah.
think that was because, the radiation we used back then, they would just irradiate those whole regions and it
Right.
just destroyed the blood supply to
Yeah.
those areas. So yeah, I
Yeah.
have seen it work for that. We
Yeah.
also use it for radiation cystitis.
Remember the two David patient? Well, one was a patient, one was his companion
Yeah,
that we
yes,
saw.
yes,
I must have treated him. He was a diabetic too, but
yeah,
I must have treated him for probably about a year for these refractory leg ulcers. They had operated on him over a pen, but he was coming to us
yeah,
because it was like a shorter drive and everything for them. And at somewhere along the line, he drops that he had had a, a bone marrow transplant, which involves
yes.
total body radiation. Which, I kept saying to myself, there's something wrong here. Why are these wounds not healing? Like,
Yeah, and I think he let that slip, what, a year, 18 months
yeah,
into
yeah,
treatment?
we were like a year more, at least a year, probably more than a year into the treatment before I found out, oh yeah, total body radiation. There you go.
Eh,
And I've seen
That
I've
may
seen crazy
be.
things with radiation. One of my mother's best friends, I had done a lumpectomy. In breast when we started doing just lumpectomies for breast cancer when the Fisher data started coming out that he would say up to 4 centimeters, but like up to 2 centimeter lesions, you could basically just excise and then radiate the breast.
Yep.
So we did that to one of my mother's friends. About a year, almost to the day after she got radiated, she comes in and all of a sudden it looks like the whole breast is sunburned, just out of the blue, like
Yep.
a year later. My mother-in-law, who had the two breast cancers, and had radiation for both times because they were like really advanced breast cancers, she got this rash on her back, again, years after the radiation was done. Went to Johns Hopkins dermatology, all these people, nobody could figure out what the hell it was. And then eventually it just went away. And I'm sure it was radiation induced. And then I'm reading an article. My brother Tony wakes up one day. He's got a cavernous carotid fistula, a cavernous sinus where your carotid artery just
Yeah.
erodes into the carotid, and your eye is almost you wake up and your eye is bulging out from the arterial pressure in the
Oh my
sinus
goodness.
system. He gets transferred he's up in North Jersey. He gets transferred between two or three hospitals. Finally, a neurosurgeon, and this is like the interesting thing was the guy I talked to him. He's a neurosurgeon. He was on the table like 12 hours on an interventional radiology table, but basically with a neurosurgeon doing the
Yeah.
doing the procedure. He got something like 350 cc's of dye. I thought his kidneys were going to be ruined, from the amount of contrast,
Yeah.
or IV contrast that they had given him. His kidneys didn't even bump, and his creatinine didn't even bump.
Wow.
He was fine. He must have great kidneys. But like
Yeah.
weeks later, he gets a ulcer on his lower back. Maybe a month or two later, he gets this ulcer on his lower back, and it's driving him crazy. He can't figure out where the hell it came from. They're putting, steroid creams and fungal creams and everything else on it. It was from the radiation beam. You know, like,
Oh,
you
wow.
know, because he had been on the table so long.
So
My family was
long.
calling me every hour, like, what am I doing? I'm down in South Jersey. They're up in like Teaneck, you know, and what am I supposed to tell them? Like, well, it takes time, you know. He did
Yeah.
fine. He refused to go back for the follow-up arteriogram, but
Oh, my
he's
goodness.
fine. You know, it never recurred. But
Oh,
yeah,
thank God.
radiation does all these weird things that, you know, and like I say, sometimes it takes time for them to show up, you know. And
Yeah.
like you said, they used to give much bigger doses. Um,
You-
you know, I remember one of my former partners, his daughter had lymphoma in the early days. I think it was Hodgkin's lymphoma. And they used to give mantle radiation where they would kind of radiate your whole mediastinum and everything.
Yeah.
She ended up with coronary artery. A lot of people got coronary artery disease near LAD, you know, because it's right on the front of the heart, and it really gets fried with that, you know, radiation sometimes. And you know, the reaction to the radiation is the artery sclerosis. You know,
Sclerosis.
as you get
Yeah.
older, it narrows, and you get she was having ischemic. She was only like in her 30s, 20s or 30s when
Uh,
this happened. You know, unbelievable.
yeah. Radiation is no joke. I mean, it does, it's great at killing the bad stuff,
Right, right.
but it also kills the good stuff.
Right. And it's gotten so much better. I mean, there's so much more
So much
focus.
better.
As a
Like,
thoracic surgeon, I really wonder if we're going to be taking out lung cancers for a while because there's pretty good. I mean, they're getting better with these small peripheral lung cancers. The results between radiating and taking them out are pretty close. I'm
yeah.
waiting to see. You know, I think time will tell, and I think it also has to do with how healthy the patient is to withstand. We don't do thoracotomies anymore; they're
Yeah.
almost all
Right.
done robotically or thoracoscopically. But you know, and most of the time nowadays they're getting wedged out. They're not necessarily getting lobectomies anymore. You know, people are doing these smaller peripheral lesions. A lot of times they're more or
Or
less getting wedged or
preserving.
segmentectomies, where you're not taking the whole lung or a whole lobe of the lung out. So the surgery is getting better too, but
Yeah.
I really don't know
Much,
where it's
much
all.
more precise.
Right. Everything is getting better and better. Unfortunately, it's also getting more and more expensive. I mean, that's, you know,
It is.
America pays twice as great. We pay like 18% of our gross national product, which is twice Switzerland, which is the second highest country in the world, second highest civilized country in the world, you know, compared to us in terms of healthcare. Our healthcare results are, you know, not twice as good. Although I think we do treat and palliate people that in a lot of other countries just kind of, you know,
Right
don't
off.
get palliated. You know, they just sort of get written off. You know, I think,
Yeah.
you know,
I,
we used to do that. You know, we used to say, stage four cancer. Yeah, you're only gonna live a couple of months. You know, so you try to make them comfortable, give them some morphine or something. You know, but now now they get immunotherapy, and people do phenomenal sometimes with immunotherapy, even in these advanced metastatic different cancers. It's amazing, but the stuff
yeah,
is
I mean, and
expensive.
that's what if, you want people to have the choice, what way they want to go. And that's the great thing about being in this country is that we
Right.
do have the choice. Like, we can choose not to try the different therapies that are available. Um,
But they
or we
are
can have
available. Yeah.
that, yeah, or we can have hope that maybe I'll be the one that that gets
Works.
better from it and gives me more time.
Right.
Um, but I mean, the costs are exorbitant, but I just, I get frustrated when I hear people get like basically bashing our healthcare system. Like, I take it kind of personal, like you're saying
Right.
it's my fault. But
Right.
I really think, like, it's not, I don't know any rich doctors anymore.
No.
Um, no, I don't know any really rich healthcare professionals anymore. It's not the providers, it's not the nurses. I don't, we're not the ones providing the care aren't the people that are getting real rich off this stuff.
No, that's for sure. Nothing
I,
compared to. There are a lot of other. My high school again was really, pretty exclusive high school, and the kids like me, when my age, a lot of kids went to, medical school. It was something they aspired to. Now, not nearly as many are going to medical school. The smart ones are all going down to Wall Street.
Yeah,
It's
they're
right.
all
It's
getting
right in New York City. The high school's right in New York City.
right.
And they're just cruising down. Kids that want to make money are cruising down to Wall Street. Just a lot more money to be made down there than
Oh,
in medicine now.
absolutely. Absolutely. So I don't know what the answer is, how to
Yeah.
fix that. I really don't. There's people that are a lot smarter than me that can figure that out. But
Yeah.
I really think like insurance companies, why I just think our insurance system is so broke.
Yeah.
Um, I have to hire I have two people now that have to spend full-time hours doing case management just to get a vascular study approved or an MRI approved
Right.
or basic dressings, wound care dressings approved for these patients.
Yeah.
So, the amount of hours that we have had to spend and it's getting worse and worse and worse every
Yeah.
year.
Yeah.
Um, the hoops that they make us jump through just to get our patients basic necessities
Yeah.
um, for chronic wounds. I I don't know. I don't know. And I think until there's some type of reform, we pay these crazy high premiums
Right.
and they're still not paying for things. So where's that money going? I don't
Right.
know.
I don't know either. And that's why I said when you see like hot topic now is of course all the illegal people in the country, and what gets me is that like the biggest problem I see with them is that they do show up in the emergency rooms, and and for when it's bad enough that people that have paid into the system. And to help people that have paid into the system at some time, even if they're down on their luck, but when you take in literally millions of people that have had like no medical care, and all of a sudden start giving them medical care, I mean, it really can break the bank. It's really just another huge load on the. That's part of the reason I think why everybody's premiums are just exploding this year as we speak. Everybody's getting their new health insurance here in new everything. Every bill I get in January is like considerably higher than it was last January.
Yeah.
You
Yeah.
know.
Well, what was it? I was looking the other day, January 28th. I've had my boys, one had knee surgery, the knee injury, knee surgery. The other one broke his wrist. January 28th, I'm already at $11,000 of my 12,000 out of pocket for the
Wow.
year.
Wow.
28 days into the year.
Wow.
So,
Yeah. Jesus.
yeah. Um,
Yeah.
but that's another story.
That's another story. Listen, we're just really been great. Really very, very interesting. I think not too many people know about wound care, and you and I both really care a lot about it. So it was really great talking to you, Donna. Thank you very much.
Yeah, anytime. Thank you so much for having me. I appreciate
Okay.
it.